Thank you. Thanks, everyone. And just first of all, unfortunately, I'm not able to speak your beautiful language, so you'll have to put up with my English. But it's an absolute pleasure to be here. And I hope that this morning's presentation is thought-provoking. I hope to kind of get some of the aspects around extended reality, augmented reality, virtual reality, mixed reality, kind of stirring in your minds as we sit here in an actual reality. So a little bit of a play on words where we say the topic of this presentation is assessing reality and starting to look at the intersect between the simulated environments that we create, that we teach in, that we learn in, and how we are starting to see the involvement of extended reality into these spaces as we try to enhance medical training for our students and postgraduates alike. So yeah, thank you very much. So I've just included very quickly here a little bit of my background. And the only reason I do this primarily is because part of my training has been conducted in South Africa. And in more recent years, I've been based at the Institute of Global Health Innovation at Imperial College London. Why I bring this up is my experiences in a South African context were very interesting in the sense that I had some of the world-leading experts, some of the world-leading infrastructure, but also some of the most resource-deprived environments that I've ever experienced. And those environments still had to be able to train and teach medicine and healthcare. And so it's always given me a kind of lens of critique in a positive way when we start to talk about new innovations and the introduction of new technology. To try and really think, how is this really pushing us forward and what environments are these particular technologies applicable to? Now that I'm at the Institute of Global Health Innovation, we're surrounded by incredible resources. And that being said, I was privileged to do a tour of this establishment yesterday. And to say my mind was blown is an understatement. It's a phenomenal institute that's been set up here. And I think seeing how these simulated environments have been really refined and optimally tuned to train medical students is really important. And as we step now into this world of augmented reality and virtual reality, we obviously have to apply the same principles in critiquing these technologies in the educational space. Part of my remit at the moment is teaching on health service delivery, measuring and improving performance in healthcare, and digital health leadership. And so again, kind of reinforcing how do we deliver, how do we improve, how do we measure that improvement, and how do we look at innovation and what innovation actually is. A good idea doesn't necessarily mean it's innovative. And as educators and people that work in these environments, we'll be constantly exposed to really smart, clever, innovative ideas. But whether they truly become innovations is to be determined. And I think that's our responsibility in this kind of field, is deciding how to make aspects scalable and how to make them applicable and appropriate to the environments that they're going to be used in. And so I encourage everyone to take on board this presentation and really critique the use of these technologies in your environments and in your spaces. So to get us started in assessing the reality, we're going to be looking at the kind of concepts around it. So we have augmented reality, mixed reality, and virtual reality. Primarily in this particular presentation, we're going to be looking at the middle one, which is mixed reality. And that's where you have a device that allows you to interact with your actual reality, as well as virtual components introduced into your environment. So these particular case studies that I'm going to present hopefully can illustrate some of the examples where you can start to decide if that was a good use or a misuse of a particular technology in that educational capacity. And so I start with a question: where is the focus? Okay, so often as educators, we want to consider aspects of engagement. We want to consider aspects of enhancing, collaborative, the pedagogy, the educational component behind what we do, and how we can use these technologies, in this case, mixed reality, to enhance that space. So I'm going to present a couple of published works that make use of extended reality in healthcare and healthcare education. And as we go through these cases, please, think of some questions potentially for later in the day where we can explore, especially if something resonates with a project that you've done or a project that you think could benefit from this type of technology. Mm-hmm. So as everyone experienced during COVID, we had to think a little bit out the box in terms of how we could deliver teaching. And one of the aspects that we had to really consider was the exposure to the clinical environments. So this led to two kind of aspects. The one was, can we remove students from the bedside, which is a problem that we see within the capacities of our hospitals, the drive for simulated environments to try and create safe spaces for people to learn and train and practice, and how these type of devices could create this very realistic experience in a ward, in an operating room, but still make students and observers feel like they are at the bedside, that they are in a real environment, that they are able to interact with the patients. And so this particular study had one clinician entering the bedside, and you can see in these images, they had virtual reality holograms that were placed in their visual field. So this is the perspective of the device wearer. And then what they could see was them being projected on a screen for students to watch at a remote location. So you can imagine there's lots of benefit to this environment. It's a bit easier. You don't have to touch anything while you're moving through the ward. You can have blood results and x-rays and that displayed in front of your visual field whilst you're interacting with the patient. Similarly, those who are watching from a boardroom or watching remotely from their laptops can also still engage with that clinical environment and move through that space safely, and hopefully still benefit from that interaction with the patient in real time. Part of education, obviously, is our assessment capabilities. As we have more and more students moving through these educational environments, the quality of that assessment becomes really a topic of exploration. How well can we assess and evaluate skills? How can we create environments where these skill sets can be appropriately assessed and evaluated? What we did in this particular trial, we used mixed reality technology for the objective assessment of clinical skills. So we took a series of surgical skills that are part of a regular examination OSCE. And we had all of our students and participants wear a HoloLens device, a mixed reality device, and they performed their various examination stations whilst wearing this device. What we then did was we had an in-person assessment taking place, and we had an assessor sitting at a remote location looking at the perspective of the wearer, the perspective of the student, to see if they could be assessed remotely. And the benefit of this then is you don't have to have assessors and students or assessors and trainees in the same environment. You can assess them from a remote location. And a third prong of this study was to record those activities and then have them assessed at a later date. And all of these modalities show to have really good correlation and demonstrated that this is possible, and remote assessment is a very feasible consideration in a surgical OSCE environment. We then took a look at how we can use these devices to generate an environment that optimizes surgical skills. So I come from a vascular surgery background. That's my training. And we have to do very fine suturing. So to put it into perspective, the suture stitch material is probably the width of a hair follicle. So very detailed, very highly dexterous movements required, and quite a tricky thing to teach. Lots of different tools, tool selection, tool usage. And so what we did was we created a kind of self-guided training environment where students were able to wear the HoloLens, look through the device. They would have a screen showing a video, instructions, which could be operated through eye movements or voice instructions. So they never have to put their hands down to move through an iPad or a computer screen. And they can keep their hands on the instruments and then practice the tutorials and go back and forth at their own pace. And this showed to have really good functionality. Another really interesting kind of use of this technology is that you can use holograms to highlight the required equipment. So as you can see here, this particular item is then swiveling in a hologram above the actual equipment itself to help with that identification, which at particular stages of training, that becomes the most important thing. Are you selecting the right tool for the job? And then are you using the tool appropriately? So starting to bring a couple of these concepts together, we then thought, how can we take these educational opportunities and make them scalable? Because something that's a good idea doesn't make it an innovation. It just makes it innovative. So testing it on a large scale to make it accessible to many people became our kind of focus at this stage as well. And we did a collaborative study with Michigan University. And we looked at if we could conduct international mixed reality immersive experiences for surgical grand rounds. So when we had particular challenging cases, were we able to have students and professionals and experts from Imperial College join experts and professionals and students from Michigan University all together in the same room in a mixed reality kind of realm, discussing patients, management, options, etc. This showed to be really effective in some ways and really challenging, as you can imagine, in other ways. So what it did was it kind of decentralized medical training because it made it accessible to people wherever you were from this remote concept. It was making use of this, they called the transatlantic mixed reality broadcasting. So we had people really across the globe collaboratively learning. It brought large audiences to the bedside. And it started to look at how you could have changes in patient care. But what I will say is that the administrative and organization that went on behind an event like this was astronomical. And I think that's where I'm starting to introduce these kind of concepts and case studies, hopefully to provoke a bit of thought in terms of what the benefits are, but what the scale of the operation potentially is in building that environment, building that situation. One particular thing to highlight is patient confidentiality, patient agreement in different countries is also different. So what could potentially be broadcasted from an American perspective was not always possible to be broadcast from a UK perspective due to different rules and regulations. So as soon as you start to scale using the technology, you then run into other potential barriers and other hurdles. So just an important thing to kind of consider. Although that being said, it was very effective. And this combination of all of these studies started to make us think, how can we use mixed reality to simulate or enhance a simulated environment, the simulated experience of emergency medical care? And so what we did was we took one of our devices and we introduced a variety of these elements in the sense of we had the virtual or the holographic screens, we had access to imaging, radiology, blood results, and the operator could use this device and walk around a simulated environment, much like those that are in the center here today. We'll see if this video plays, but loaded in this was also elements of protocols in terms of how to perform specific procedures. And the students or the trainees would be given a case. In this particular example, it was a chest injury where the patient had sustained a pneumothorax, a hemopneumothorax, should I say, and they required a chest drain insertion. So as a surgical trainee, inserting a chest drain is part of their curriculum and something that they should aspire to do, but it can be very daunting and often requires supervision from a senior member of staff. And so this particular use of the device was trying to leverage a couple of entities. Could we bring remote assistance into the equation? Could you be given support from a remote location as the trainee? Could you then make use of protocols, blood results, X-ray images in the holograms around you to help you make your clinical decisions? And then could you use the holograms displayed on a patient to identify areas of safety? What was really beneficial about this is almost the video stream. So if I am a senior registrar and I get a call from a junior doctor, I can see what they see. So I might not be able to come to the bedside because I'm busy with other clinical duties, but I may be able to see them and help them direct to select the right equipment, to apply their techniques to the right area, the safe area on a patient, instead of just verbally communicating that. So there was a lot of real benefit to this. The other thing was it keeps their hands free, as opposed to going to a phone, picking up a phone and discussing. They can activate a call through the device. So it was bringing a kind of element of enhanced care to a simulated environment and helping these trainees be guided and facilitated. And just to kind of discuss some of the results around this, what we found was through introducing elements like the holograms to help them select the correct tools. We had a remote, this is the entire sim environment, but this is the visual perspective of the trainee, and this is the senior registrar providing assistance. They've got their various parameters, and they've also got access to guidelines that could come up in a hologram, so they could make reference to the guideline and then perform the activity. And through the combination of this as an option, we found that when we measured errors, how many errors a trainee made, the errors were substantially reduced when the introduction of mixed reality technology was provided to the trainees. A number of trainees providing standard care, access to phones, access to protocols on the intranet, access to protocols in a file. So all of the same kind of instruments, but potentially a bit separated, once consolidated in a mixed reality device, became a lot more accessible, efficient, and usable. And a number of trainees who would potentially either cause harm was reduced. A number of trainees who wouldn't proceed because they felt they didn't have the skill sets or the confidence, they were then given the confidence to proceed. And so the number of total errors measured in the study dramatically dropped. So we would say this was obviously a very good example of how you can use virtual reality, mixed reality, and technology in a simulated environment to enhance patient outcomes. So, after seeing a number of those cases where we make use of holograms, we make use of remote access, the integration of protocols, images, blood results into your holographic space, into your reality, the ability to talk at the bedside with clinicians at a remote location, to discuss protocols in environments, to enhance those environments either clinically or in a simulated environment. It all sounds very positive, and it is. And seeing somebody put a HoloLens on or a device on for the first time and a big smile and wow and interacting is a remarkable thing. It's a really lovely thing to see people engage with new technology and the excitement. But I want us to think about a couple of things. Does it bring quality or does it potentially form a limitation? So some of the buzzwords that I think we should consider: connection, scalable, reliable, sustainable and adaptable, inclusive and accessible, acceptable and appropriate. And I think these words start to become really important when we consider the use of these innovative technologies in our simulated environments. So when I say connection, I think in today's day and age, this is probably what we all think about. We think about Wi-Fi, we think about compatibility, even between a PowerPoint presentation and a device and a Mac, and the user interface becomes a potential hurdle. But when I talk about connection as an educator, as a doctor, as someone who authentically wants to enhance the experience of those trainees that move through our programs, this is what we're actually talking about. We're talking about the educational goals, the interactions. Is it meaningful? Do the trainees get to experience ownership of their learning? Are they being immersed in an environment, or are they still remaining observers? Just because you put on a virtual reality lens doesn't mean you are immersed, although it is an immersive technology. You may actually be very distracted. It has the potential for immersion, and it has remarkable capabilities. but it could be more distracting in some environments than it can be. And it becomes a very observational thing rather than an immersive experience. And I think as educators and trainers, this is a very important thing to consider. Scalable, sustainable, and adaptable. So when we establish various educational properties, for example, teaching people how to do a vascular surgery procedure, very intricate, very detailed, very time consuming. So we talk about making it scalable because we can record, we can create autonomous environments for trainees to go and learn at their own pace, at their own time, with their own device. But if there's any adjustment or adaptation required, it's almost back to the drawing board. So when you're developing these protocols, we have to think of ways to make them adaptable. We have to be able to update them frequently because that's the world that we live in. So these simulated environments that we're trying to enhance do need to be agile. What expertise are available? Just because something is really good doesn't mean that you will always have the expertise available at your institute. And that's why I make reference to South Africa. Some of those institutions have world-leading experts and others are completely resource deprived. So creating remote teaching opportunities is phenomenal because you could be in a rural village far away from a big institute and you can still learn at a very highly sophisticated university with remote learning, using a HoloLens. But what if you need technical support? So these things become really important considerations. So continuous support and challenges, and the risk of these entities becoming outdated is very high. Inclusive, accessible, acceptable, and appropriate. So there's a financial cost, the creation and the experience, the pros and cons. There's the ethical and clinical environments, as I alluded to with the Michigan and Imperial, both world-leading institutions, but had very different approaches to certain entities and aspects. Learning differences that we see in our trainees, various disabilities. What about data protection in this kind of simulated virtual reality world that we're embarking on? We've got very strict data protection rules and regulations and protocols set up for many aspects of our training and clinical environments. But what about those that exist in a virtual world, in a virtual space? And your organizational resources. So I think it's just really important to recognize that these technologies are phenomenal, and we have seen the potential to really shape and enhance the simulated environments as well as the clinical environment. And they have got almost limitless potential, but it needs to be well considered and really well thought out, not only in terms of its usage, but where it will be used. So later on today, we have a workshop that will explore this a bit more, but I really want to start encouraging that thought process about how it can interact with your learning objectives, your learning outcomes, and your clinical space, your educational space, and how it can be integrated with other core principles so that we don't become distracted by the fancy, innovative idea. We start to really use it to optimize what our primary goal is, which is around really furthering the clinical training of our practitioners. So after participating in the cases and the studies that I've presented, as well as many other aspects, I realized that there was a really important skill set that we require as educators in the medical world. And this is something that we have been doing all the time when we work in simulated environments. We get introduced to a new technology, a new idea, and we subject it to critique and discussion, and we evolve the plan and the idea. And so what we decided to do was to create an extended reality version of this. How do we get introduced to new technologies and consider their use in our medical educational settings? And so we've got this course, which is available on Coursera. So if anyone is interested, please do go and have a look, and I welcome any feedback as well. But if you are applying for funding or a grant and you win that funding or that grant and you get access to good resource and you go out and you purchase technology and then you try to make it work in your environment, it's almost being done through excitement, which is lovely and wonderful, and we should be excited about optimizing our educational environments. But this course and this concept largely looks at how do you get access to a resource and how do you appropriately integrate it into your educational environment. And so it helps you to differentiate between the types of extended reality that might be the best suited for what you are trying to achieve. So you have mixed reality, as I've discussed today, but maybe your learning outcome is better achieved with virtual reality or augmented reality or reality. Or maybe you have certain aspects of your training that will benefit from a myriad of these. They don't all have to be achieved using a mixed reality lens from start to finish. And I think that's where the quality of your teaching experience can really be enhanced, is through that appropriate selection of the innovation that we have got at our fingertips. So where is the focus was the question at the start of today's session. And I think we very quickly focus on the shiny and the new and the exciting prospects of innovation. And I think it's a wonderful thing to have energize us. And then we do need to remember the responsibility that we have as educators in making sure that these phenomenal advancements in technology are appropriately integrated into established learning principles, educational outcomes that really do enhance the experience of our medical trainees. So for yourselves to consider, what is the rate limiting step in your educational journey that you are trying to create? And how can the technology that is available and on the market these days really start to enhance that, rather than find the technology and then see where it will best fit? I think it should be driven the other way. So on that, I just want to say thank you very much for your time and your consideration. Thank you.
Thank you, Jason, for incredible presentation. Lovely. It was very interesting indeed. I have a lot of questions, but first I will give some opportunities to our audience. Any questions, please, from the audience? If not, I will start, and maybe I will inspire some other colleagues. So I will start with a very specific question, because you mentioned a study where you measured the effect of the technology or the intervention, and you measured it by medical errors or improvement of some performance, I would say. And my question is, how did you record the medical errors, and maybe how did you also classify them? Because I can imagine that there are errors associated with the technology, but also some human factors.
Excellent question. So in the study, we have got a validated error tool. It's called the IceCap error tool that we've used previously in vascular surgery training at Imperial. And it looks at the categories of procedural elements. So can you follow steps 1 to 10? Equipment, so selection of equipment. It looks at communication. It looks at non-procedural related. So for example, if there was an interruption or something that happened in a theater. And it looks at a variety of these errors. And what we found with that particular study is that the biggest decrease in error was procedural. So where following the process and the protocol was optimized through the use of the mixed reality device. And we also found that equipment selection was and when you think about it, it makes a lot of sense, because it's making accessible the information that would have been there anyway, but now you've got potentially someone guiding you instead of hearing it on the phone and then going or seeing it, and having all that information kind of available at the same time is what we believe really made the big difference. It didn't really impact communication error. So there was a couple of entities where you saw there wasn't really any benefit. And so that's why I say, if you're trying to create a session that is going to work on the communication skills of your medical trainees, would that potentially enhance? It's a very expensive device. It's a lot of money to spend on something that may not actually have an impact on the very core learning objective of that session or that experience.
Maybe there was a question.
Thank you. I was wondering how exactly to frame this question, but I'm going to try to frame it in the easiest possible way. For many people, experiencing VR or AR can be exhausting, demanding. So I was wondering if this factor manifested in any of these studies.
Yes, absolutely. So what we did with all of these was we had a separate, kind of more qualitative entity to it as well, where we asked people, have you been exposed to virtual reality or extended reality before? Did you have any side effects? Like you say, the fatigue related entity, the vertigo, that, there's a number of aspects which make this a non-suitable option for some of your medical students. And so we have reported those findings in each of those publications as well. So you're testing me to recite them. But what I will say is that it does exist, and it's a really important consideration because the duration of your session, much like a lot of our other educational sessions, how long can someone concentrate for? If you're learning in person, if you're watching a video on a screen, there's a lot of evidence to suggest that these modalities have to be well considered. And this is exactly one of those. You have to consider, what are you asking of your participant? If they're going to be in a virtual reality for the whole day, where the learning will stop and the survival will kick in. They will just try to survive the experience. And that's why I'm saying you need to really be balanced in the use of this. It cannot maybe achieve learning outcomes 1 to 6, but it may enhance learning outcome 4. And that's probably the way to start to think about the use of these technologies. So I hope that answers the question. Thank you.
Any other questions, please?
Yeah.
Hi, Martin Komenda, Masarykovy University, Faculty of Medicine. Nice to meet you. Thank you very much for the excellent presentation. My question is quite simple. You mentioned OSCEs and holograms and this very impressive scenario. Can you shortly describe three target groups, like faculty management, teachers, or OSCE observers and students, and their opinion which they have on this particular scenario or concept in practice? Because I think these three groups will differ in the opinions because of cost, expenses, also something what is really innovative, and they must invest some kind of energy which should be quite time consuming. Thank you very much.
Absolutely. Thank you for the very good question. From a technical support, it's very high demand. It's got a very high demand because you are setting up, you are establishing what's appropriate from an educational point of view as well. You are often able, certain OSCE stations are very easily transferable because you don't change anything. Yeah. They're established, you put the lens on and you perform the lens. The students really enjoyed the concept. Mm-hmm. But in reality, they often found that they almost wanted to look under or beyond the lens instead of through, which then from an observer point of view can pose challenges, because if you are relying on observing to mark and your student is looking at the roof, it becomes difficult out of the visual field. And so there is an onboarding process in order to be able to use those devices, which has to be factored in. But I don't think that would be dissimilar from integrating an iPad, when technology allowed us to move from notebooks to laptops, from laptops to iPads. There was always going to be a degree of onboarding. So I think it's good to recognize, but not to be deterred. I think we can establish pathways for that. But what I will say is, for example, suturing, cannulation, history taking, examination, as OSCE stations work really well. When you want to create an environment, which I suppose is appealing to everyone here, simulation and its fidelity becomes the question. How real is that environment, and how much does our student feel they have been examined in a very real scenario is sometimes the goal. And what we found with one of the holograms is that you could have a patient that deteriorates, and they could become very unwell. So they can come in out of breath, and then they can show elements of respiratory distress, and then they proceed to respiratory failure. And observing your student or your trainee adapt their plan as the patient deteriorates is a very good exercise. But if that's the first time your student is going to be exposed to that environment, will also be associated with a lot of stress. And so putting them into a real environment in a clinical setting to experience that, and then also examine them on it, is obviously why we create simulated spaces for safe educational opportunities that can mimic real life, but at the same time not cause anyone any harm. And so the ease with which that was created, once the program exists, was phenomenal, because then you just let the scenario run and you've got your rubric and you mark your students appropriately and see how well they manage. So that's very easy to create, because then all you require is a small room with a lens, and you can see what the student sees. So you can see the patient. I don't even know if you would have recognized that that patient was in fact a hologram. Yeah. I don't know. I'll quickly go and see if everyone can see. But it's so realistic. This patient here. And, and once it's set up, it's phenomenal. But getting it set up is from a technical point of view, you need the expertise. So, but it received well, and it also received with challenges by all groups, I would say. So yeah, great question.
So, thank you very much.
Thank you.
Ladies and gentlemen, Jason Lawson from London Imperial College.
Thank you.